Okay, everyone, looks like it is about time for us to get started. Some folks may trickle in here the first few minutes, but we'll just go on ahead and launch in because we have a very exciting presentation today. My name is Meg Bruner, and I'm with the Northwest ATDC. I'm sitting in this month for our usual host, Jennifer Verbeck. We're very excited to bring you Dr. Sarah Leyde today to talk about medical complications of methamphetamine use. But before we dive in, I just wanted to quickly run through some logistics. Next slide, Dr. Leidy. All right, first off, if you have questions for our presenter, please type them into the chat box at any time. And after Dr. Leidy is finished with her talk, we'll try to answer as many of those as we can. Next slide. You'll also be getting an email later this afternoon that has a link to a quick little survey in it. Please take that survey as it helps us make sure we're bringing you the content you're interested in. Plus, every survey response helps us continue to offer these free or low-cost events like today's session. That email will also have a link to download the slides in it, as well as a link to our website where you'll be able to find a recording of today's session, and that will probably be available tomorrow morning at the latest. Next slide. Additionally, we'll be sending everyone who attends the full session today a certificate of attendance, and it takes us about a week to get those out. You don't need to do anything to get that certificate unless you're watching this in a group. If that's in the case, please just have someone in the group email us within a day with the names and the email addresses of everyone who wants a certificate in that group, and you'll see our email address right there, northwest@attdcnetwork.org. Next slide. Okay, now on to our session. I'm pleased to introduce today's speaker, Dr. Sarah Leyde, who is a board-certified internist and addiction medicine physician. Dr. Leyde is currently an assistant professor at the University of Washington and the associate program director for the UW Addiction Medicine Fellowship. In addition to providing clinical care and medical education, she leads quality improvement and research projects focused on enhancing primary care and cardiovascular health for people who use methamphetamine. Thank you so much for being here with us today, Dr. Leyde, and we're looking forward to hearing from you today.
Great. Thank you for the invitation to do this talk. I'm really honored to be here and excited to talk with you about the medical complications of methamphetamine use, strategies for prevention, harm reduction, and treatment. Um, in addition to this regional land acknowledgement you see listed from the ATTC, I'd like to offer a more specific acknowledgement for the land on which the University of Washington is located. So I acknowledge this land as the traditional home of the Duwamish, Muckleshoot, Suquamish, and Tulalip tribal nations. Without them, we would not have access to this working, teaching, and learning environment. And I take the opportunity to thank the original caretakers of this land who are still here. Oh, I can see the webinar view on Zoom is always interesting because I can't see who's I can't see your faces on the screen, but I see a lot of hearts bubbling up on one of my screens. So thank you. Yes, I think this land acknowledgements are really important. Before we dive in, let's briefly touch on some learning objectives. So by the end of this talk, you should be able to recognize some key differences between methamphetamine overamping and opioid overdose, because recognizing these differences has really important implications for harm reduction. Number two, by the end of this talk, you should be able to identify some common medical complications of methamphetamine use and review strategies for prevention and treatment. I realize this is a multidisciplinary audience, so this overview isn't necessarily so you can treat this stuff yourself or prescribe medicines, but so you can advocate for your patients to get what they need out of our often very dysfunctional healthcare system. I will also include some specific meds and doses for any prescribers on the call, but I'll try to avoid using too much medical lingo. Number three, we will review some case studies of innovative programs and brainstorm together how to help individuals who use methamphetamine get their medical needs met. As you can see today, we will not be touching on specific pharmacologic or behavioral treatments for methamphetamine use disorder itself. Instead, during this short, 1 hour talk, we're going to really be diving into the medical complications. So I'm going to start with some disclaimers about my role and viewpoints, and then we'll move on into overamping, medical complications, and the case studies I mentioned. Okay, so some disclaimers for you. So though I have addiction med training, first and foremost, I am a primary care doctor. As such, I aim to work with people who use methamphetamine to improve their general health and well-being. And for some patients have a goal of abstinence, this means working toward abstinence, but for a lot of people, it doesn't. And it's all about improving quality of life, improving health, reducing harms. Like many doctors, I come from a place of privilege. I myself don't have lived experience of methamphetamine use, and this is why I find it really incredibly helpful to work on the multidisciplinary team that I do, especially with peer support specialists. So shout out if we have peer support specialists in the audience, and would love to hear your perspectives on all of this. Um, let's see, I'm seeing a comment here. The slides I see in the chat. Okay, I'm gonna let the okay, I think maybe the wrong link was put in the chat. Okay, I'm gonna let you guys figure that out. Um, okay. Uh, so Um, yeah, so very curious, to hear what anyone with lived experience of stimulant use on this call kind of thinks about this content. My last disclaimer is like, I don't think methamphetamine is a bad molecule. In part, I'm just saying this to like be provocative and like make sure you're awake for the webinar. I'll just say though, like methamphetamine is a medicine that I can prescribe. The FDA recognizes its utility. Um, and I'm not saying this because I think you should prescribe it, but just to point out the fact that we are often like so focused on demonizing the molecule that we are often missing the big picture. So, what actually harms people who use methamphetamine is the war on drugs, poverty, stigma, the drug supply that makes it really difficult to know the quantity and quality of the active ingredient you're trying to put in your body, and the factors that really lead people to use stimulants in the first place. Um, so my patients use methamphetamines for a lot of very understandable reasons, and some derive significant benefit from their use of methamphetamine. At the beginning of my visits with patients, I often like to start out just by asking what people like about methamphetamine. What does it do for them? And I often hear things like counters side effects of fentanyls, um, helps with safety on the street at night, keeps them alert to work three jobs in this era of late stage capitalism, treats pain. We often think of opioids, as being, I was surprised by this. Like, I don't always think of like methamphetamine being effective for pain, but I hear this a lot from my patients that there is some analgesic property. Treats ADHD, right? Because they can't find a prescriber to treat their ADHD. Melts away internalized homophobia during sex, gives them stamina during sex work, and also like just feels really good. So there's that. And I think it's important to recognize that there can be really significant downsides too, including negative impacts on health and well-being, cravings, and loss of control, leading to the development of a substance use disorder. Challenges with physical safety while using methamphetamine, impacts on life roles and goals, impacts on relationships, stigma, and then legal system involvement. Um, I hear this misconception a lot. A lot of people, I guess, a lot of doctors assume that if you use methamphetamine, you have a use disorder. It's actually about 50% of individuals who use methamphetamine meet criteria for a stimulant use disorder. So that's kind of where I'm coming from and my sort of lens through which I'm viewing this. We're going to next move on to discuss overamping. So when I talk with other physicians, nurses, healthcare professionals, and even when I go to addiction medicine conferences, I am really floored at how easily we all lump together drug overdose, or some people prefer the word drug poisoning, into one category, when in fact, opioid and methamphetamine toxicities are distinctly different entities. So, opioid overdose is really well defined. All opioid overdose includes two things: the person is not breathing or not breathing well, and they're difficult to wake up. Um, Methamphetamine overamping is much less well defined and can really occur on a spectrum ranging from mild to severe. And overamping can look different for different people. Might include symptoms like anxiety, palpitations, chest pain, hyperthermia, paranoia, psychosis, seizures, heart attack, and stroke. Um, because it can look so different for different people, it's important to ask your clients what overamping looks like to them and what symptoms are most uncomfortable for them. As I'm sure all of us recognize, opioid overdose or drug poisoning is often life-threatening unless promptly reversed with naloxone. In contrast, methamphetamine overamping again occurs on the spectrum from mild to severe. And unlike opioids, where overdose is really, like when it comes down to it, related to the opioid you just consumed, right? It's the fentanyl you smoked seconds to minutes before you stopped breathing that like really led to this. Um, Methamphetamine is a little bit different. Often, deaths due to methamphetamine are more due to chronic methamphetamine use and the damage methamphetamine is causing the body over many years. For example, when a 60-year-old with decades of methamphetamine use comes in with a heart attack, we can't necessarily blame that on the methamphetamine they just smoked that morning. Rather, it's really, again, decades of damage from methamphetamine-induced high blood pressure that puts them at risk for that heart attack. So while opioid overdose is, more closely linked to dose and tolerance, methamphetamine overamping, and especially the psychiatric symptoms like psychosis, may be more related to factors like not sleeping for several days, really significant malnourishment, severe dehydration, etc. And as the climate crisis unfolds, it's also really important to mention extreme weather, as methamphetamine can increase the risk of hyperthermia. And this has really important implications for harm reduction. So, the tenets of overdose prevention for opioid use are naloxone, not using alone, medicines like methadone or buprenorphine. When we think about overamping prevention for methamphetamine, it turns out that helping our patients get sleep, ensuring adequate nutrition and hydration, and providing protection from extreme weather and temperatures, and last but not least, access to high quality and non-stigmatizing primary care and behavioral health care are absolutely key. Now, I do want to recognize that, polysubstance use is very, very common. And although naloxone won't do anything for methamphetamine overamping, it's really important to offer all of your clients who use methamphetamine naloxone. And this is because, they might choose to use opioids. They might run into, a situation where they share a pipe with someone and there's like residue, fentanyl residue on the pipe, or they might just be more likely to be around people who are using opioids and might be able to save a life. I saw a patient yesterday who um, told me that he has reversed 70 overdoses in the past 4 years with naloxone. So I always tell my friends who don't really work in this sphere, like our patients save way more lives than we do, right? Like empower people to save lives, give them naloxone. Um, Interestingly, a couple of years ago, there were like all these headlines about the stimulant supply being contaminated with fentanyl. And that like hasn't really turned out to be true. So at least in my region, in Washington State, only like 1.5% of the powder sold as or the material sold as methamphetamine is contaminated with fentanyl. So that's actually rare. Like when you buy the methamphetamine, it's like usually meth. But again, contamination on shared pipes is common and really problematic. So give everyone naloxone, even though it won't reverse methamphetamine overamping. Um, okay, so moving on to medical complications of methamphetamine use. Um, so, when I'm assessing a patient, I really try to hone in on a few key systems to see whether the person is having health issues related to their use. This figure is a bit simplified in that methamphetamine can actually affect way more organ systems, can affect the lungs and the kidneys, etc. But these are the big ones, and I like to keep these categories like in the front of my mind when I'm seeing someone in clinic. And of course, like all of these categories are really important, but I want to be clear that the two toxicities that end people's lives who use methamphetamine are cardiovascular and neuropsychiatric toxicities. So we're going to start by reviewing cardiovascular toxicity. So methamphetamine can cause several problems, including high blood pressure, pulmonary hypertension. So that all that means is just high blood pressure in the blood vessels in your lungs. Heart failure, which we'll take a deep dive on, abnormal heart rhythms, heart attacks, aortic dissection. So this is when the largest blood vessel in your body, the aorta, the walls of that blood vessel actually tear, and it can be life-threatening, and then stroke. So we're going to jump into a case and a bit of a deep dive on methamphetamine-associated heart failure because I really want to empower you, like whatever your role is in this field, I want to empower you to recognize this early and help your patients get the treatment they need. By the way, all the cases I present are like loosely based on my own patients, but names and identifying details have been changed. I'm not using any photos of my patients. So case one, um, Bill is a 35-year-old individual who engages with your harm reduction organization for support and supplies for safer methamphetamine and fentanyl use. They mentioned to you that they've been feeling poorly over the last few months with swelling in their legs and difficulty breathing. You accompany Bill to urgent care. He's not going to go alone. He's felt really stigmatized by the healthcare system in the past. So you bring him there, and the provider is concerned about heart failure. And the diagnosis is confirmed with after blood work and a heart ultrasound, also known as echocardiogram. After a brief hospital stay, he's discharged with instructions to take 4 new medicines daily, some of which are dosed multiple times a day. This is someone who's never had to take medicines daily before. Bill is told to stop using methamphetamine, but not given any kind of like referral to any kind of clinic that would help with that, and to follow up with a cardiologist. So we'll get back to Bill's case later. But for now, I'll invite you to kind of nerd out with me for a second about the pathophysiology of methamphetamine-associated heart failure. So as you all know, methamphetamine is a stimulant. It activates your fight or flight sympathetic nervous system. And this is what leads to the fast heart rate and high blood pressure that we see with methamphetamine use. Us humans evolved to have that system go off rarely. For instance, when our ancestors were about to be eaten by a tiger. Unfortunately, when that sympathetic nervous system is like firing frequently over many years, it can lead to heart disease. The blood vessels in the heart tighten up because of the stimulant, and then the heart muscle doesn't get enough oxygen, which is known as ischemia. Also, the walls of the heart, because of that high blood pressure, get stretched out. And so both of these processes can lead to heart failure. What heart failure means is that the heart, which is just a pump for your body and your blood, can't pump effectively to meet the body's needs. Methamphetamine is also directly toxic to heart muscle, which can cause fibrosis, which is just basically scarring. And so this mechanism can also lead to heart failure. Now, what happens when people have heart failure is that the heart cannot effectively pump the blood throughout the body. And so fluid backs up into people's legs and lungs. And so common symptoms of heart failure include leg swelling, gaining a lot of water weight, difficulty breathing, especially when they're laying flat, and fatigue. So if you see people with these symptoms, like please get them in to primary care as soon as possible, or urgent care, or the ER if they're really having difficulty. Unfortunately, we're seeing like really young people in their 20s, 30s, 40s develop really severe heart failure related to stimulant use. As long as there's not too much scarring or fibrosis in the heart, this process is actually reversible. And what we need to do to reverse it is two things. One is really the mainstay of treatment for any type of heart failure are medications. The medications are very, very effective in kind of remodeling the heart and helping it to pump effectively. The other thing that can really help with methamphetamine associated heart failure is addressing the methamphetamine use, so having people cut down or discontinue. Um, so, uh, you know, it's interesting looking at the cardiology guidelines because they just say like, hey, just like have people take these meds, have people quit their methamphetamine use, and we should be good. And obviously, we know like it's not that simple. And for people who have really difficult social circumstances and are dealing with the cognitive and psychiatric impacts of methamphetamine use, and trying to seek care in a healthcare system that hasn't traditionally treated folks who use drugs with much respect, this can be just really, really challenging. There's a ton of stigma out there, and I see lots of people with really severe heart disease just, not engaging because of it. We see patients with methamphetamine-associated heart failure kind of go in and out of the hospital. It's like a revolving door, but never really get like the substance use care and outpatient cardiology care that they need. So, how, kind of stepping back and keeping in mind like all of the cardiovascular conditions that are associated with methamphetamine use, how do we promote cardiovascular health? Um, so, heart disease prevention is the same as in, it is in anyone. So, excuse me, heart healthy diet, regular exercise, which by the way, is also showing promise in helping people reduce their methamphetamine use. If you think about it, like when you exercise, you release a lot of natural endorphins, and you're activating that same fight or flight sympathetic nervous system. So there's something about exercise that actually might help people cut down on their methamphetamine use. And then certain medications can be helpful for prevention too. So if a patient has had a heart attack or a stroke, they absolutely need to be on a statin medicine. That's a medicine that cuts down on both cholesterol and inflammation in the body, as well as aspirin. When people haven't had a stroke or heart attack but are at risk of having one, us primary care doctors use certain calculators to determine a patient's risk of having an event. And this helps us counsel people on whether the juice is worth the squeeze to take these medicines. But methamphetamine use is actually not in any of these calculators, even though it definitely increases your risk. So my expert opinion is for us to providers to actually think about statins for people who use methamphetamine when conceptualizing kind of their overall risk of developing heart disease and maybe to have a slightly lower threshold to prescribe. So for detection, we need to get people in to see a primary care provider for evaluation. Primary care providers can consider ordering a BNP, which is a blood test that shows how stressed out your heart is. And if it's elevated, definitely makes you think about heart failure. And then an EKG or heart tracing, and then especially if either of those are abnormal, an echocardiogram, which is a heart ultrasound to directly visualize how well the heart is pumping. The medications we use for methamphetamine-associated high blood pressure or heart failure are just like the same as in other patients. There was this thinking for decades that medicines called beta blockers, so things like metoprolol, carvedilol, etc., were dangerous in people who use stimulants. And this was based on case reports from the 1980s, and that's been debunked. So if your patient like needs a beta blocker, they should be offered a beta blocker. Um, so um, moving on. Bill comes back to your harm reduction organization a week later, seeking your advice. They treated me like shit in the hospital, he tells you. He describes experiencing stigma related to his substance use. He feels scared about the diagnosis of heart failure and doesn't understand what it really means. It's a really scary term, right? He worries he will die soon. He did pick up the meds from the pharmacy, but hasn't remembered to take them regularly. And he can feel the symptoms coming back, the swelling and the shortness of breath. His methamphetamine use continues unchanged. So this is a very sad outcome, obviously. but I want to keep it real for everyone. And like, this is what I see most commonly. So at the end, we will bring it back to this and talk about more systems levels changes really needed for these patients. All right. So moving on to the neuropsychiatric system. So a lot of people know that methamphetamine use is associated with psychosis, impulsive behavior, leading to suicides and accidents. Fewer people recognize that methamphetamine use can also cause really significant cognitive impairment, which shows up as poor memory, difficulty with inhibition control, and slower processing speeds. People who use methamphetamine also develop Parkinson's disease at a much higher rate than the general population. So we are briefly going to touch on methamphetamine-associated psychosis with a case. So Tracy is a 48-year-old individual frequently admitted to psychiatric emergency services with erratic behavior, visual hallucinations, persecutory delusions during periods of methamphetamine intoxication. After 24 hours in the ER, her symptoms clear. In the past, she has declined daily oral or long-acting injectable antipsychotic medicine, saying, I don't need these, most of the time I'm fine. I'm not going to use meth again. We're going to be okay. Um, so let's talk about psychosis. So if you talk with people who use methamphetamine, you'll find that many people have experienced some kind of transient psychotic symptom while using. So this might look like seeing shadows or feeling like really, really paranoid. And around 36% of people experience psychosis that lasts beyond that period of intoxication. Now, if people stop using methamphetamine, about half of those 36% will experience resolution of their symptoms within a week, but a sizable amount of people will continue to experience psychosis for a long time, months, years, even though they've stopped using. And this is termed persistent psychosis. We still don't have great clarity on this phenomenon, and it really remains unclear if like genetic and environmental vulnerability just triggers the development of like a primary psychotic disorder like schizophrenia. And then, of course, we all know we have patients who can't or don't want to stop using who are just experiencing psychosis like all of the time because their body is being exposed to methamphetamine continuously. So for patients with persistent or chronic psychosis, case management, antipsychotic medicines, non-pharmacologic behavioral health treatments can be really helpful. But what do we do for our patient Tracy, who only has psychosis when she is actively using, which isn't that often? So I want to bring up this newer study. This was a really cool study that came out recently about olanzapine assist packs. So olanzapine is an antipsychotic med that's pretty sedating. And in the study, they gave olanzapine, just 4 tablets, only 4 tablets, to patients upon discharge from the psychiatric emergency services department. So just 4 tablets was associated with significant reductions in psychiatric emergency room utilization at 2 and 6 months. And I find this really compelling. I'm really looking forward to seeing the results replicated in a randomized control trial, which I believe will be underway. I believe there are plans to do this RCT. Um, and, some people have talked about this. There's been sort of these concerns sort of raised like, oh, should we like trust our patients to do this and know when they should be taking the medicine? And some people have likened this to the early days of naloxone, right? When the sort of discourse right in our field was like, should we give people who use drugs naloxone? Should we trust them with that? And now we all know, like, it's obviously a very good idea, right? So this is there's no like reversal agent for methamphetamine overamping or overdose, but maybe this is the closest thing we have. And I think this study is very compelling. So stepping back, how can we promote general neuropsychiatric health among people who use methamphetamine? So in the prevention category, sleep, the importance of sleep cannot be understated, and maybe things like, PRN as needed olanzapine can help. Exercise, addressing substance use, avoiding other substances that can cause psychosis, like cannabis and cocaine. I don't think we ask about cannabis enough in my state it's legalized. And so all of a sudden it's like we don't talk about it. But cannabis can really be associated with quite a lot of psychosis for some folks and is something that should be addressed. Interestingly, animal studies of statin medicines among mice exposed to methamphetamine show significant cognitive protection. This has not been replicated in human studies, so I'm not like, putting all of my patients who use methamphetamine on statins. But I'm thinking about it, especially if they have risk factors for cardiovascular disease and after, shared decision-making sort of conversation. Interestingly, there's lots of statins to choose from, but interestingly, atorvastatin has really good blood-brain barrier penetration. So that's the statin of choice for my patients with methamphetamine use. For detection, we want to get people into medical care for proper diagnosis. For treatment, again, chronic psychosis can be treated with antipsychotics, either daily oral or monthly injectable, which can be really useful for obvious reasons. And then considering low dose olanzapine. So Tracy accepts a prescription for as-needed olanzapine and has no further psych admissions. Tracy follows up with her PCP for ongoing prescriptions and enrolls in an SUD treatment program and does well. Moving on to sexual health and infectious disease. I think I'm running a little short on time, so I think I'm going to go ahead and skip this case and just point out that infectious disease is spread among individuals who use methamphetamine by actually several routes. So there's injection drug use, obviously. There's obviously sex. However, an underappreciated route is shared pipes. So there is a concern for transmission of things like herpes virus, COVID, and flu, and even hepatitis through shared pipes, especially when people are using pipes where the glass has cracked. Like they're actually pretty fragile, and especially if they have sores or other skin conditions near their mouth. So the infectious diseases we see associated with methamphetamine use include HIV, hepatitis B and C, endocarditis, which is just a fancy word for heart valve infection, syphilis. So syphilis is huge, at least in my little corner of the world. It's very tightly linked with methamphetamine use. Gonorrhea, chlamydia, trichomonas. So how can we promote sexual health and reduce infectious disease? So this is where preventive care and harm reduction like really shines. So one thing we can do is discuss with people, switching to safer routes of substance use. And then safer injection practices, super important to talk about. I tend to ask people not like, oh, how do you use meth? How do you use your methamphetamine? Like maybe you start with that, but you should also always ask like, when was the last time you injected? Right? Because a lot of people smoke methamphetamine and and inject it rarely, right? So if you just ask more generally and just stop there, you might not like uncover the fact that they're sometimes injecting and you might miss that opportunity to have that really important harm reduction conversation. Um, so safe injection practices like cleaning the skin beforehand, using sterile water, avoiding reuse of needles, avoiding sharing needles, avoiding licking the needle, things like that are really important to talk about. Condoms, lubricant, the same vaccinations that we give to other folks in primary care, and then PrEP for HIV prevention. So I'm sure most of you have heard of PrEP, but it's possible to get on a daily pill or even an every 2-month injectable medicine to prevent HIV. And then DoxyPep, which is brand new. So I'm going to tell you just a little bit more about that on the next slide. Next is detection. So we need to be offering regular testing for sexually transmitted infections. Every 3 months for people at higher risk. And then don't forget to test all the sites of sexual activity, including oropharyngeal and rectal when appropriate. For treatment, I think it's really important for clinicians to have a low threshold to offer empiric treatment, meaning treating before the test results are even back. So if someone comes into clinic, right, or if you bring your client into a primary care clinic with a sore on their genitals that looks like syphilis, we don't want to wait for the test to come back. Just offer an injection of penicillin. We also really need to lower barriers to HIV, hepatitis, and STD treatment. So for instance, in the UW system, we used to have people like see their primary care doctor and then have a separate meeting with the pharmacist before even receiving Hep C meds. And it was really comprehensive care, but that actually introduced like a barrier, right? Because they had to like come back so many times before they even got meds. Now there's a lot of excellent work being done by like Jocelyn James, Maria Corcoran, et cetera, to streamline these processes and really get people hooked up with medicines immediately, and also treat people in the ER and inpatient. Um, Lastly, and very importantly, we need to make clinical spaces safer for people with minoritized sexual orientation and gender identity, and do more like in-reach into local organizations where people already feel safe. Very quickly, I want to mention DoxyPEP because this is new. I'm not going to go over all of the details on this slide, which kind of outlines a recent randomized control trial looking at doxycycline. But I'll just say that among cisgender men who have sex with men or transgender women who are at higher risk for sexually transmitted infection, DoxyPEP, which is just 200 milligrams of doxycycline within 72 hours of condomless sex, reduced the incidence of bacterial sexually transmitted infections by 2/3. So very effective. And we're starting to do more of this in clinic. Patients like it, low risk of side effects. The study, only included people assigned male sex at birth. And so we don't really know if these results are generalizable to people assigned female sex at birth, but you can have a discussion about that with your patients and can still prescribe it. Okay, moving on. So we have two systems left. We're going to do a quick blitz through some common skin conditions associated with methamphetamine use. So parasitosis is really common. Parasitosis meaning people coming in thinking that they have some kind of infestation or parasite. Sometimes they truly do have a parasite or infestation, like scabies, like bed bugs. And sometimes they don't. Sometimes it is delusional. And this can be really hard to treat because people often come in like really feeling invalidated by the healthcare system. My approach to this is to validate the distress, so the emotions they're feeling, explore the role of methamphetamine. So, even if people really think that the problem is coming from a parasite, a lot of people will be able to recognize like um, that maybe methamphetamine still makes this worse and might be willing to address their methamphetamine use. Occupying hands in another way. So it's helpful to keep like fidget spinners, like those little spinny things in clinic. Um, and then antipsychotic medication can be helpful as well. Methamphetamine can make the skin really itchy, and sometimes people develop these nodules because of like constant scratching. It's called prurigo nodularis. For that, you want to give people like moisturizers to put on the skin, and then steroids, either injected or in a cream or ointment for these skin nodules. Skin and soft tissue infections are common, can be associated with injection, but also don't have to be. And then also chronic lower extremity wounds are often related to a history of like lower extremity injection drug use and leading to damage of the veins. And then oftentimes people use methamphetamine like don't have adequate nutrition, hydration, and so that impairs wound healing. Okay, so we are going to quickly talk about oral health. Um, I've been thinking so much about oral health lately. I think it's like a real shame that like I didn't learn anything about dental health in medical school, and it's like so relevant, and people have a hard time making it to the dentist. So we need to like put the mouth back in the body and think more about this. So methamphetamine causes a bunch of different dental concerns. Dry mouth, methamphetamine itself is acidic. People, grind their teeth. All of these can cause cavities. So we want to encourage people to brush their teeth twice a day, but avoid brushing immediately before or after smoking. They can do baking soda rinses after smoking because baking soda is basic, and so we'll neutralize the acid. Xylitol gum, dry mouth washes for dry mouth, mouth guards, prescription toothpaste, quarterly fluoride treatments. We're exploring this option for our clinics. And then obviously regular dental care. Okay, in the last couple of minutes, we're going to talk about how to work the medical system for your clients. So I love this quote from this research study led by Brittany Blanchard, one of my colleagues at UW. Um, this was a qualitative study exploring patient and clinician perspectives on harm reduction in primary care. And this patient said, don't tell them to stop. Obviously, we know what we're doing, we know what the effects are and the consequences. I think they should think more about what they can do. So this quote really stuck with me, right? Because what I learned in medical school was to like educate people and tell them to stop. And that just like we need to approach this differently. So I'll just open it up to the group and maybe people can just put some stuff in the chat real quick. What do you think we can do without additional funding within the confines of our healthcare system to improve medical care for people who use methamphetamine? I'll give people a couple of minutes to put in the chat like any ideas you have for what we can do in our current kind of healthcare system to improve care. Okay, treat people like they're human. Stigma is one of the primary reasons people avoid medical care 10 years into recovery, still have shitty experiences with new healthcare providers. Thank you so much, Christopher. So well put, so important. Effective communication. Um, thank you. Focus on more awareness, reducing stigma. Yes, we're getting so much into stigma, which is so important. Um, remove proof of residency requirements for access to harm reduction. Wow. Uh, educate health providers to reduce stigma, acceptance. These are so wonderful. Assign specific providers who have better training on, yeah, yes. Um, outreach. Yeah, I love the outreach idea. Yes, Maureen, thank you. Yes, people deserve primary care. These are so great. Go to the doctor and hospital with your patient. I love that. Make care less siloed. Thank you. Utilize peers. Yes, hygiene kits. Better training. Ah, these are so wonderful. Okay, gonna move on because we have one more activity to do together. Um, so thank you, everyone. So much wisdom in this Zoom webinar. So this was like the list I came up with, and I think we hit on like all of these. Oh wait, Denna's comment's really good. Ooh, I'm like getting all these ideas for my clinic. Thanks, guys. So yeah, like being flexible. If people show up late, like try to see them anyway, if you can. A short visit even. Come out and say hi at least. Find supports, simplify med regimen to daily dosing. Um, you can even consider bubble packs, right, which make medication use a little bit more streamlined throughout the day. Help with navigation, transportation, write patient instructions down. So there's some evidence that actually like auditory learning is more impacted with methamphetamine use. So don't assume anything you say to your patients during the visit is going to be remembered. Actually, like writing stuff down in simple terms is important. Developing a whole network of providers and specialists who get it and are going to treat your patients well, and leveraging community organizations. Wonderful. Okay, and then quickly, if you were given money and time and the directive to design a medical clinic or healthcare system for people who use methamphetamine, like what would it look like? Just like dream big, no barriers. Money's not an object. What would you like? I'm just curious if people can throw in the chat what they would do. And just because we're running short on time, I want to just kind of go through while you're kind of putting stuff in the chat. I want to go through some case studies of places that are trying to make this happen. So one of these places is full disclosure, I work there, Hobson Clinic and Hobson Place. And shout out if there's anyone from DESC or Harborview on the call. So this is a really cool clinic. Where DESC, which is a mental health and housing nonprofit, is integrated with University of Washington Harborview Medical Care. And so Downtown Emergency Services Center, or DESC, does housing case management, mental health case management, psychiatry. They have a really phenomenal substance use team and innovative buprenorphine program. And then in the same building, we have the kind of traditional medical services, including a cardiologist, a great pharmacist who does a lot of low barrier Hep C and prep care, and our own substance use team as well. And then you can see this picture. So, like the top floors with the blue and yellow windows, that's actually where people live. So, there are 177 studio apartments. It's permanent housing for people who are formerly experiencing homelessness. So, we're really trying to like put as much as we can under one roof. And I'm like super, super excited that we just got a big grant. I found out a couple days ago, got a big grant to um, beef up our stimulant use disorder like programming and treatment there. So we'll be offering low barrier contingency management, hiring another peer support specialist to do that, and hopefully like lots more harm reduction and stuff too. So if you can put it on under one roof, that's always great. And even though we're just a primary care clinic, right, we actually provide safer smoking kits and safer injection kits, as well as naloxone, fentanyl test strips, and harm reduction advice. Um, I want to be mindful of time and save some time for discussion and reading your comments. So I'll just give quick shout outs and then we'll end. There's also the Community Heart Failure Program at Harborview Medical Center, founded by Jamie Petchin and Kate Smith. They are cardiology nurses and nurse practitioners. They just do their heart failure care in the community, shelters, libraries, street, Jack in the Box, wherever it may be. And this, they're not specifically providing like addiction treatment per se, but really, um, uh, you know, changing what they do to meet the needs of the patient. And instead of expecting the patient to come to a cardiology clinic where they've previously like been stigmatized. So shout out to them. I just want to quickly mention the START Clinic at Boston. This is probably like the gold standard for stimulant use disorder care. And the link down here, and you can just Google it too, like they share all of their materials. So they have like really great protocols on overamping, great harm reduction literature for methamphetamine in Spanish and English. And they share all of their protocols. So if you're interested in like revamping your clinic, you can look at this. And then this was a program that I helped develop as a fellow at UCSF, where we actually had like cardiology and addiction clinicians working together, and doing contingency management for people with heart failure. And you can read about it if you're interested, through these publications at the bottom. So again, like we need to think more about what we can do for our patients, not just like expecting people to stop their substance use. And I think I'll end with this quote, just be honest and truthful and show that you care. I think this came up a lot in your comments, like the relationship is the treatment. The relationship is just absolutely foundational to being able to offer primary care, substance use care, whatever it may be. So thank you so much. My email's here if you want to like nerd out more about this, and open it up for questions. And then if there's no questions, I want to read some of your comments out loud.
Great. Thank you so much, Dr. Leidy. That was an amazing talk and also just very engaging. I learned a ton. And you're fun to listen to, which is always nice. So I haven't seen any questions come in. Lots and lots of comments though, and I can send you a copy of this chat too, just so you have a chance to see everything. Does anyone have any questions? If so, throw them in the chat. And to get us started, I had just one question for you. I thought it was really interesting what you said about statins as a neuroprotective treatment. Do you know, like what's the theory on why statins would be effective for that?
Oh, that's so interesting. I need to like educate myself on that and like do a deeper dive on the animal studies. I do think, it's interesting because we used to think of statins as just like cholesterol lowering.
Yeah.
But then, there's been a lot of literature in the past decade or so about really these like anti-inflammatory effects of statins. So I wonder if it's more that
Um,
mechanism that's leading to cognitive protection. Um, so, hopefully we'll have like some like human studies, right? Like probably we won't have a controlled trial, but maybe some kind of study to to give us like more insight into how this works in humans. But for now, I'm just really like having a low threshold to offer statin treatment, especially if people have high blood pressure, smoke cigarettes, have high cholesterol, right? Those are all good reasons to think about it.
Interesting. Thank you. All right, one question has come in. One person is interested in hearing more about neuropsychiatric issues with cannabis and methamphetamine use, says many of their clients who use meth share that they use cannabis to help come down, and they live in Iowa where cannabis is not legal.
Hmm. Yeah. And then I'm seeing like Mark had a question about
Oh yeah, I can
cannabis
also
too,
check that.
maybe. Yeah. I think I don't know too much about this either, and I feel like the addiction medicine, addiction psychiatry, like literature is only recently kind of moving in the direction of studying polysubstance use, like, right, like what happens when people are using more than one substance and different combinations of substances. We have very little information on this. But I'll just say, I think cannabis is a less harmful substance in general, I think. And so often it can be used as like a harm reduction tool, right? Like people who use opioids might choose to switch to cannabis or use cannabis to like treat their opioid withdrawal symptoms. So I don't want to like say too much bad stuff about cannabis, but I think it's important to recognize that for some people, not everyone, cannabis can be associated with really significant psychosis. So, all that I'll say is if you have a patient with methamphetamine associated psychosis, I think it's really important to ask about cannabis and cocaine because, like, maybe they're not interested in reducing their methamphetamine use, but like maybe if they are interested in reducing or discontinuing their cannabis or cocaine use, like that might have an overall benefit for their mental health. So I think we have a lot more to learn about that topic.
Interesting. I found Mark's question, and Mark says that he lives in Hawaii where methamphetamine has been a problem since the 80s. He's an emergency medicine physician. Most of my patients are living outdoors and don't follow up in clinics. I'm curious how much methamphetamine your patients are using on a daily basis. It's not unusual for my patients to be using an 8 ball, 3.5 grams on a daily basis.
Yeah, I mean, I think it's variable, right? I have yeah, some patients who are using like in quite high quantities. I have other patients who like they might not have like a use disorder, but they might have ADHD and can't find a prescriber to prescribe them stimulants, and they are literally taking tiny amounts of methamphetamine, like packaging them into their own pills and taking it like someone with ADHD would take their daily like Adderall, right? So it just like the spectrum is wide. But yeah, I have a lot of patients who are taking high quantities too.
Right. So with the shortage of primary care providers, who do you think is best suited to prescribe? And is this something mobile crisis units could do for street outreach?
Um, excuse me. Hmm. Yeah, I think I think mobile crisis units could do this. Do you mean like Dana, do you mean like stimulants or prescribed stimulants or you mean like anti-blood pressure, blood pressure medicines and heart medicines and that kind of thing?
I don't see that. I'm assuming they mean like treatment for the health issues that meth
Yeah,
users
no,
experience.
yeah, I think it's like you're absolutely right. Like primary care is sometimes really hard to access. So, um, I, I mean, I think, the biggest thing with like prescribing statins or blood pressure medicines is it does require like follow up, right? You want to like make sure the meds you're prescribing are working. And so it would require follow up, but I think as long as there's some like continuity of care, the ability to do the appropriate like blood work follow up. I mean, I would empower mobile crisis units to do this because especially like blood pressure medicine, statins, like these are relatively safe medicines to prescribe.
What is the reaction from patients or providers on safer smoking kits? Do you get negative feedback on that? Has there been any research done on the outcome of providing those materials, like health-wise for patients?
Yeah, I think that literature is just in its infancy, and this is one of the reasons I have so much respect for the harm reduction movement, grassroots movement, which really like I'm always very careful about not like co-opting, right? Because this like started in the community by people who use drugs for people who use drugs long before it was politically popular or legal, right? So, anyway, all that to say, I think really like safer smoking supplies started before there was evidence for them, and I think we're just starting to see some of that research come out. We have had like I think an overwhelmingly positive response in our clinic. I mean, I work at Hobson Clinic and Harborview, so like I work in the safety net with people who enjoy taking care of people who use drugs for the most part. But so the response could be different elsewhere, but we've had really overwhelmingly positive experiences and the patients love it. And I think it's like putting our money where our mouth is. It's so different to like say you're a doctor who believes in harm reduction. Um, and it's like a whole other step to be like, hey, do you want a bubble today? Right? Do you want a fentanyl test strip? Hey, I have needles here. Or let me order you the size of the gauge of needles that work best for you. Like that is like a whole different level. And I think it really helps with the therapeutic alliance and helps people's like health and well-being. Um,
Next question. Oops, it just jumped away. Do you yourself prescribe patients medication for ADHD like Adderall? And I think they're asking, do you do that with patients who have a history of meth use?
I do. Uh-huh. Um, so there were some guidelines, the American Society of Addiction Medicine, and kind of paired with the Addiction Psychiatry Organization and came out with some guidelines in 2023. And stimulant prescribing for stimulant use disorder made it into those guidelines. So the overall evidence for this is like pretty minimal. Like this is not like buprenorphine or methadone for opioid use disorder, which works incredibly well. Like this doesn't work as well, but there is some evidence for prescribing methylphenidate specifically for people with methamphetamine use with or without ADHD. The guidelines stipulate that this should be done by addiction med or addiction psych providers, like people who can carefully weigh the risks and benefits and monitor the patient really closely. So this isn't something where you like give them 3 to 6 months of stimulants and say like see you in 6 months. Like we do a lot in primary care. And then in some states it's legal. In some states, it's like gray area. In some states, it is not legal to prescribe stimulants just for methamphetamine use disorder. So I can email me if you want like more info on the legality, but I am starting to do this in my clinic. And for some patients, it's been helpful. I've been really surprised, like, unlike, opioids, people aren't like losing their prescriptions and coming back early and requesting higher doses. Like I've actually had the opposite experience where I'm like, hey, do you want more? Do you want more? Do you want to get back on that methylphenidate? So I don't know. I think we're still learning, honestly, but I am doing it.
Thanks. Right. I think that's all the questions we have today. Lots of thanks in the chat. I do just want to mention that next month our webinar is also going to be on methamphetamine. It's about transcranial magnetic stimulation, part of a CTN study. And I'll put a link to register in the email that I'm about to send out. And I also wanted to mention that ADAI is hosting a one-day symposium on meth, focus on meth. And I think Dr. Leidy is part of that as well. So if you want to hear more from Dr. Sarah, as someone just called you in the chat, Dr. Sarah, you can come to that and I'll add a link to that in the email as well. Thank you so much, everyone. Thank you, Dr. Leidy. This was really great. Really appreciate everyone's time today.
Yeah, thank you. Also, I really want the comments because I
Okay,
didn't
I
get
will.
to
I'm
read
going to
through them, and
send.
we got this grant, and I want all of
Oh,
your wisdom
nice.
and ideas. So,
Great.
yeah,
I will
definitely
send you the
email me
chat.
those. Okay.
I will
Thanks, everyone.
absolutely. All
Appreciate
right.
it.
Thanks, everybody. Bye
Okay.
bye.
Bye.